Hi, thanks for tuning in. Got an amazing case for you today. Takayasu's arteritis, and we're going to ask a simple question. Got pulse. So we're using combined EchoVascular here, and we're going to show how non-traditional imaging can really improve our understanding of the pathophysiology of this lesion. So here is the traditional view of the aortic arch. Now notice that I've switched to a high frequency probe. So I'm getting a lot of dropout here, but I can see the left common carotid and the subclavian artery. Okay, now I've angled the probe a little bit more towards the left subclavian and left common carotid artery, and I'm starting to see some very fuzzy echoes here, but this still isn't good enough. So we're going to go to a fully modified arch view here in just a minute. Yes, a little bit more, and now I'm starting to see some echoes here, some thickening, and just a little bit of a lumen here in the left subclavian. All right, so now I've done a full modified aortic arch view. I've tilted the probe all the way towards the left common carotid so I can see the longest segment possible. So quite a bit of thickening here, but this is edematous. It's a lot of fluid, so it's very hard to see, and it looks like it clears up at this point. So this is the longest segment possible I can see from the suprasternal notch using a high frequency probe. So here's our question. Can we see pulsation in this artery? No, there's no pulsation in this artery. Only had two cases where I couldn't find a pulse. One is severe aortic stenosis, and another one is Takayasu's arteritis. So we do get a little bit of movement from the aorta, but overall there's no change in diameter here. So there's a real danger that this thing could seal off completely. And 40 to 60% of these patients will respond to steroids and other drugs like methotrexate if that doesn't work. But 20% of these patients are not going to respond to anything. And once this thing seals off completely, then you have to consider surgery, doing a bypass graft from a right carotid to the left carotid, or using stents. And that's a very difficult, dangerous stuff. So we like to find this stuff early. Okay, so color Doppler helps to identify the lumen and gives us an idea of the thickness here of the walls. And we get a little bit of flow here. So we can see this long narrowing, and this did cause a bruit. The doctor could hear a sound with a stethoscope when it's placed on the neck. A little closer view looking at how the color Doppler outlines the lumen here and the tremendous thickness. That's got to be 4 or 5 millimeters of thickness here. So the color Doppler again shows this continuous flow pattern, and it could be that the sound is being produced right here where you have kind of a little bit of an obstruction. So pulse Doppler shows this rounded, blunted waveform. Okay, should angle correct here, but still we can see the pattern of blunting. All right, so I've leaned over to the left subclavian artery, and I gave it my best shot, but as far as I can tell, this artery is not patent. So there's several different types. Type 1, we know we have that. Type 2A involves the ascending aorta and also sometimes the coronary arteries, the aortic arch, and branches of the aortic arch. Type 2B involves the thoracic descending aorta, or in this case, the whole thoracic aorta, with involvement of the type 2A. Type 3 involves the thoracic descending aorta, abdominal aorta, and or renal arteries, and I would add mesenteric artery as well. Type 4 involves the abdominal aorta and or the renal arteries, and this is the kind that Dr. Takayasu found. It's so interesting how he did this. He had a patient who came in every 6 months for hypertension, and he checked the femoral pulses. And the patient came in, and he couldn't feel the femoral pulses. And he asked him to come back in 2 weeks, and the femoral pulses had returned. So that's how he was able to use deductive reasoning to discover this type of inflammation. He reasoned that the abdominal aorta must have been either completely obstructed or severely obstructed enough to stop him feeling the pulse. And this is our type here. Type 5 is a combination of type 2B and type 1. So it's really important to note that all of this stuff comes and goes. It could be here one day and be gone the next. Can look completely normal and swell up and then become completely obstructed. So let's look at the long axis. We can see the ascending aorta here. There's some suspicious areas, but still not anything conclusive. So again, I'm going to have to use a modified view to better show the pathophysiology. All right, now we can see that the ascending aorta is not involved, and that's great because when it is, that's the type that involves the coronary arteries, and that can be really serious. But that's only about 10% of Takayasu's arteritis. Okay, I'm looking for any kind of nodules on the aortic valve. I don't see them here, but sometimes I see these little funny nodules on the valve that gives me a clue that we might be looking at Takayasu's arteritis. Okay, how about this coronary? Does that look normal to you? Probably it is. We'll have to see if that's going to be adequate enough, but so far I'm saying that ascending aorta is not involved. So we're going to look at the four-chamber view. There's no hypertrophy here. Mitral valve, I'm not seeing any nodules on the mitral valve. We've got good function. Okay, so again, I'm using a modified imaging here to show the thoracic aorta. And it's just too blurry to tell for sure what's going on. Okay, I've changed to a 4 megahertz probe now. And this is why ultrasound is not really used for Takayasu's arteritis that much. This is where most of the problems come along in older patients. And I'm trying to say, is that the wall of the aorta or is this it out here? Really have to be looking for it and able to see it. Okay, so I've rotated the probe. I'm back up in peristernal, looking at this thoracic aorta, and no, I really can't tell that there's anything wrong with this thoracic aorta. All right, but when I slow it down and take a still frame, over here you wouldn't notice it, but with the color I can kind of see that there's some thickening here and some more thickening here. So in real time, yeah, it's tough to call. Unless you were really looking for it, you'd probably just skip over. Okay, so I'm going to change probes. This is a thin Asian female, and I'm able to get in here and see, yeah, that's really suspicious looking. Okay, so I've increased the frame rate by using the zoom to 53 hertz. And I'm just wondering, is all of that thickening of the thoracic aorta? Possibly. Okay. Again, with a 4 megahertz probe, it's really hard to tell. But you can give it a try. All right. So again, I'm really having trouble seeing the walls of the aorta here, but I'm getting a very strong signal from the superior mesenteric artery. Let's see the pulse Doppler. Yeah, this one really threw me. I thought this was a trace at first, and later on I could see that it was aliasing and really such a high velocity that it was coming up around here, so way over 3 meters per second. This is a really interesting finding. When the doctor listened to the abdomen, she could hear an abdominal bruit, and it's probably coming from this. And this is probably audible sound, creating a very strong signal, a very high velocity, like a coarctation of the superior mesenteric artery. Okay, so we're in a transverse plane. Here's our aorta with this suspicious blurry stuff around here. And this is the left renal artery. And these are frequently involved. And yes, there's a very high velocity here. So renal artery stenosis. We're going to look at the right renal artery now. And quite a strong signal here. And again, a very high velocity. So mesenteric and renal artery stenosis. So this shows an infant with Takayasu's arteritis, and all we get here is unexplained left ventricular hypertrophy. So I use these views on all these non-traditional views on all the teenagers and young adults that I see. A modified aortic arch view, check the thickness, check for pulse, and I want you to remember, even though this is a young Asian female, it can occur in any race, at any age, but especially in teenagers and young adults. It's often misdiagnosed as depression or laziness, so it's really important to have a really good look at the left common carotid and the left subclavian artery. So I hope you found this to be useful information, and if you did, please, if you could just click the like button, and if you know some other sonographers who might be interested in learning these non-traditional imaging methods, please share this. Thank you very much.